All right, so welcome along to this coaching corner in October. Hopefully we're nearing the last of our lockdown sessions and we get to open up hopefully by the next time I come and see you next month, which will be super, super exciting. Anyway, tonight's topic is B mode evaluation of the heart, what you need to look for when you're in a hurry. So what we want to just cover very briefly in this recording today is what's the scope of a point of care echo and what does normal and abnormal look like on B mode, and what are those key signs that you can look for that tell you that something significant is going wrong. So point of care is fast becoming this very low cost, easy tool. We can use stuff that's handheld now, and even on the little handheld systems, we can actually make a lot of really crucial diagnoses so that we can get an answer very quickly. And even with the most basic machine and the handheld machines, we can actually see quite a lot. And when the patient is in the extremes of illness, that point of care echo scan can be very, very useful. So, it includes, but not limited to, evaluation of hypertension, cardiac arrest, cardiac trauma, if patients experiencing chest pain, or even if they're post-surgical patients. You can do a rapid and very limited echocardiogram and see the extremes of normal versus abnormal so that you can make those life-saving decisions and management decisions, treat your patient and get them on the road to recovery sooner. The challenge with that point of care exam is, however, that it is usually done in a very time-constrained manner. We're not looking at a full echo exam. It is not a full echo exam. I am a general qualified sonographer that can do basic B mode echo. There is a whole lot that you can tell on an echo exam without doing any fancy measurements. And for those patients in extremis, this can be very, very helpful. So we're going to look at the 4 basic views, looking at the parasternal long axis, parasternal short axis, the apical 4, and the subcostal 4 chamber view. In reality, you may only have time for one of these views, and even one of these views can give you quite a bit of information for that patient who is really, really sick. If you only have time for one of these views, in some circumstances, it doesn't even have to be a perfect picture, and you can still get quite a lot of information. So ideally, we are aiming for really good quality images, and we're trying to always try to do a better job. But there are times when even a very average view and one picture, not the whole 4 series, can tell us a whole lot and be very helpful in taking the right management decisions for your patients. So I'm going to look at those 4 basic views and assess the 4 basic views essentially in the same way for each view. And to start with, come up with a mnemonic, whatever, SMS, like your text messages. We're going to look at the size, motion, and then how much squeeze. So in each view, we're going to evaluate size, motion, and squeeze as a way to give us an indication of whether this heart is normal or not. So let's start with the normal parasternal long axis view. We want that parasternal long axis view. We start by having the depth set a little more generously so that we can you see my arrow up on the screen here?
Yes.
My finger? Yeah, good. So we want to have the depth set quite generously so that we can see this descending aorta, because to start with, that surveillance depth, that'll give us an indication of whether there is pleural fluid or pericardial fluid. Pleural fluid comes below the descending aorta here, and pericardial fluid will sit above the descending aorta. So we start with the surveillance depth so that we can see that descending aorta at the bottom of the screen. And we want to focus on the left ventricle. We want the mitral valve to be sitting just to the right of the center of the screen. And we want to obtain the image in a high parasternal window as we possibly can. Now, usually in the normal heart, the apex will not be visible. We're trying to aim for this interventricular septum to be parallel with the ultrasound beam. No, our ultrasound beam hits it at right angles. So it We want them parallel. So, and then we're looking to find the largest cavity diameter. You may need to tilt your probe to get a good view here. We need to be able to see both the aortic valve and the mitral valve clearly in this view. And we're looking for the three chambers, so the left ventricle, the right outflow tract, and the left atrium. Finally, when we look at the parasternal long axis view, a normal parasternal long axis view will apply the rule of thirds. So as we are looking at this parasternal long axis view, the right ventricular outflow tract, the aorta or ascending aorta, and the left atrium should all be roughly equal in size. Now, no, we're not getting out a measurement. We're just eyeballing this. We're just going to look at it and see, are they roughly about a third each? They should be roughly equal in size. Now, if they're not equal in size, then that starts to tell us a story about what's going wrong. So, first problem that we can have is that the right outflow tract is enlarged. And so we can start thinking of what are some of the reasons for why the right outflow tract might be enlarged. So here we have normal on the left, and on the right image here, we have an enlarged right outflow tract. Now, what are the sorts of pathologies? Maybe it's a pulmonary embolus, other sorts of things. You've worked through those questions about what causes enlargement of the right outflow tract. If the middle third of the picture, again, we have normal on the left and on the right, if the middle third of the picture or the ascending aorta is enlarged, what causes that? Well, it could be an aneurysm. And lastly, we look, again, normal on the left, abnormal on the right. The left atrium here is enlarged. And so what causes left atrium to be enlarged? It might be congestive cardiac failure. So the next thing we look at on this parasternal long axis view is motion. Now, if we look here at the normal view, we can see what the normal motion of the mitral valve looks like. So when we look at this mitral valve leaflet here, and particularly the anterior leaflet, we can look at how close it's coming to the interventricular septum. And in the normal heart, that should almost kiss the interventricular septum and should open up quite a lot. So if we look at the separation between this anterior mitral valve leaflet and the interventricular septum, it should be between 0 and 8 millimeters in the normal patient. And again, are we getting down to the nth detail? There are measurements that you can make. You can do M-mode measurements and you can measure this and get your millimeters of stuff. But in the first instance, what we want to just do is look at the B-mode image and see, is that mitral valve leaflet moving? When it's not, it becomes quite obvious. So on this image on the right, which has severely reduced motion of that anterior leaflet of the mitral valve, you can see that it does not come anywhere near this interventricular septum. The next thing we're going to look at is how much squeeze is there. So here's an example of the parasternal long axis view, again, normal parasternal long axis view that shows normal fractional shortening. Now, fractional shortening is the term that we call the technical term for how much squeeze is there. The left ventricle is contracting and the septal wall and the posterior wall of the ventricle come closer together in systole. We're now looking at the change of the left ventricular cavity. And so we should see these ventricle walls come closer together as the heart pumps. The left ventricular cavity size should change by about 25 to 40%. And again, once it's severely abnormal, you can see that there's not so much squeeze in this heart. Now, intuitively, as you look at the picture, you can see that heart doesn't look so well. But can you classify what's actually going wrong? So if we're looking at the size of the left ventricle, the size of those chambers, we're looking at the rule of thirds there, and then look at the mitral anterior leaflet of the mitral valve. It's not moving so nicely either. And then there's not so much squeeze. And all of those things together start to put some tags onto, well, what is it about it that's not normal? Now, one way that I look at the squeeze of the heart to see if it's working properly. As the heart squeezes, the ventricle wall should also thicken. But I find it hard to look at the heart when it's just beating away normally. It looks like it's squeezing. But what I tend to do here is if I cover up the bottom half of my screen there, then it makes my eye focus on the ventricular septal wall to see if that wall does thicken as the heart squeezes. And then when we come over and see this abnormal wall, you can see if you cover it up, there's not much activity happening there, and there's not much thickening of that interventricular septal wall as the heart squeezes. So the next view that we look at is the parasternal short axis view. And what we're trying to get here is the most round picture of the left ventricle that we can get. We should see both papillary muscles, and they should be about the same size. And I think of these papillary muscles here like little Lego hands. I don't know if you're familiar with, if you put together as much Lego as I have, you know the little Lego hands that I mean. And I think the papillary muscles there look like little Lego hands. When we're in a good cross-section here and in the short axis view at the level of the papillary muscles, we shouldn't see any mitral valve and we shouldn't see any aortic valve. In this view here, we should see both the left ventricle and the right ventricle. You can see the right ventricle here gives that left ventricle a bit of a cuddle as it wraps around the left ventricle. And we center on the left ventricle. So if we look at the size, you can see here normal in the middle. Now if we look at the reduced size, you can see the size of the left ventricular cavity is quite reduced in this image on the left and quite enlarged in this image on the right. As well as an enlarged, we also have on this increased one, we also have an enlarged right ventricle as well. And you can see that sometimes the motion of the septum appears to be bowing inwards, particularly over here. We have a really quite large right ventricle and there is bowing of the septum towards the left ventricle. So and that's called paradoxical motion, which we'll talk about a bit more in a minute. So in the parasternal short axis view, the motion of the septum should be, all sides should be coming towards the middle as the heart squeezes. If we look at the ratio of the sizes between the left ventricle and the right ventricle, you can see here in this abnormal heart that the right ventricle is much bigger than the left. And we can also notice here that the left ventricle walls are really quite thickened. We want to look at the motion. And again, we come back to that size, motion and squeeze. So when we're looking at the motion, we're looking at the motion of the septal wall. So as the heart squeezes, it all comes in equally from each side towards the middle. In this instance here, you can see that the motion is not quite as we expect. In systole, it's bowing the opposite way. Now, when I look at wall motion, I personally find it a bit tricky, and maybe I just haven't done thousands and thousands of them like the echo sonographers have. But I find it tricky to figure out, well, which side of the heart is actually not moving properly. And so what I tend to do is, again, cover up half the thing. Is that side of the heart moving when I've covered it? Cover on the other side. Is the top side moving? So you can see when you've got a normal wall motion, it all squeezes towards the center in systole. You can do it either side as well to help you narrow down on where is it actually not moving in the right way. So as we look at this one here and we cover it up, the top doesn't look too bad. It looks like it's squeezing and the wall thickness is increasing slightly. But when we look down the bottom, it makes it easier to see where the, hang on, let me get that video going again. So this looks all right. And then when we come down the bottom, you can see that it's not squeezing evenly as all towards the center as we're expecting. And as I said, I find if I cover up half the screen, it starts to help me figure out which side or which part of the ventricular wall is not moving, or to show that to highlight that it isn't moving as I'm expecting. The next thing we look at is how much squeeze there is. So in the normal heart, it should come in by 25 to 40%. Another way you can look at this is poke your finger. I know some of our team call this wet willy. Put your finger in the middle of the ventricle and make sure that the heart is squeezing and coming in evenly from all directions. And you want to see it come towards your finger in systole. Whereas when it's not beating or not pumping well, it doesn't squeeze as much, and you can see that it's not coming in as much as we're expecting here. The next view we look at is the apical four-chamber. So what we're aiming to see here, we should see the four-chamber, 2 atria, 2 ventricles. The left apex is in the screen's midline. The septum should be vertical. The heart should be oblong, not round. If it's rounded, we're foreshortening it a little bit. We haven't got our angle on the heart right. And we should have a four-chamber view where we get the maximal right ventricular diameter. So first of all, we assess the size of the chambers here to determine whether it's normal. So again, we've got that rule of thirds and things seem to be divided into 3. The ventricles should be about 2/3 of the length of the heart. The atria are about 1/3. If we compare the right and left side of the heart, the right side of the heart should be about the 0.6 and the left side about 1. An easy way to remember this is to say the right ventricle is about 2/3 the size of the left ventricle. So if your right ventricle looks the same size as the left ventricle, then it probably is enlarged. Now you do need to check and make sure you've got your probe around the right way and we've got the right side on the right side so we don't get it mixed up. But if those ventricle sizes are about even, then something's going wrong. So here you can see that apical four-chamber view of the heart and the rule of thirds. So the ventricles are about 2/3 the size of the whole heart in its length. The atria are about 1/3. The right side, the right ventricle, is about 2/3 of the size of the left ventricle. So when we look, we have an example of normal here and abnormal on the right. The right ventricle in this clip looks to be about the size or maybe even a little bigger than the left ventricle. Now, the other thing that we start to look at is the apex of the heart in the normal heart. If we look over here, the apex of the heart should be formed by mostly the left ventricle. In this example here, you can see that the apex of the heart is made up of more of the right ventricle. And so when that apex is dominated by the right ventricle, that's also another indication that the right ventricle is enlarged. So if we look at this example, normal on the left, abnormal on the right, with the apex of the heart comprised mostly of the right ventricle. The size, we're looking at the size. Now we move on to the motion. So one of the categories, or one of the things that we look at, is ascent of the base of the heart. And this is where we observe the movement of the heart along its vertical axis, or from the base to the apex during systole at the level of the tricuspid and mitral valves. When the left ventricle has a normal ejection fraction, we expect the heart to show good movement of those valve annuluses. More is normal. If those valve annulus, whether it be the tricuspid valve or the mitral valve, if those valve annuluses are not moving well, then it tells me that something is wrong. Now, yes, there are measurements. You can take a TAPSE measurement. And that's great if you want to take and put a number on it. But if we practice getting used to looking at the B mode, you can actually tell a lot from the B mode. So here is the normal heart motion, and we're looking at the motion along the vertical axis, and in particular, looking at the movement and the motion here of the valve annulus. Now, the tricuspid, or the TAPSE measurement in particular, is a measurement where we run an M mode through that tricuspid annulus. So if we have normal as the example on the left here, and when the heart is not moving well, you can see this mitral valve, for example, this mitral valve annulus is not moving terribly much. And again, the next thing we're looking at is the squeeze of the heart. So here's an example of normal on the left and a bit of atrial flutter on the right. Is it squeezing in the manner that we're used to seeing it squeeze? So once you have looked at lots of normals, it means abnormal stands out quite a lot more easily. Here's an example of a poor ejection fraction. So you can see here, there's not much motion of these ventricular walls coming towards each other. In this case, the mitral valve annulus is not moving terribly much. Here we have another one where you can see that there's not a whole lot of squeeze, and the squeeze is not doing what we expect it to do. And this is an example of global hypokinesis. So the last view we look at is the subcostal four-chamber view. In this view, we should be centered on the tricuspid valve. The heart is oblong in shape, and we should be able to see both atria and both ventricles. Both the left and right heart is seen in this view, and we shouldn't have the aorta visible if we're in the right plane. So let's start by looking at the size. Again, the right and left, the size of the right and left ventricles can be compared. The size of the atria and the ventricles can be compared. And when we start to notice the differences in size here, you can see that this heart has something quite badly wrong. Very enlarged right ventricle, very enlarged right atrium. If we look at the motion, again, you can see the squeeze. We can see that tricuspid annulus moving. Here, that free wall here is bouncing around like there's a little man jumping up and down on the trampoline. And when we look at the motion of that free wall of the right ventricle, we can start to see that something's going wrong. That draws our eye to this big load of fluid here. And this is the case of cardiac tamponade. And some people describe this like imagine, I've seen an animation, I wish I could do it. But anyway, they've got this little man jumping up and down here like they're jumping on a trampoline. So when you see the free wall of the right ventricle jumping around like that, there's something definitely wrong. And then, of course, when there's no squeeze at all, in this case, we can see cardiac standstill. So that's the quick tiki tour of how to evaluate the heart using just B mode. Yes, there are a lot of measurements. The problem with measurements is that you have to have a really good B mode picture and be in good plane for those measurements to actually mean something. So if we get used to looking at the heart as a first step in your learning journey of how to go about assessing the heart, and especially if you're in a point of care environment where you don't have a lot of time to do those measurements, we want to look at each of those views and assess them for their size. Look at the motion and then look at how much squeeze there is. If we can work through those three things, like send an SMS, check the size, motion and squeeze, that can start to help us define what's going wrong and what the problem might be. I'd like to just say a big hats off to Dr. Chris Fox at University of California, Irvine. He has very kindly let me use some of his images in this talk, and without them, there wouldn't be much to talk about. So thanks so much, Chris. Does anyone have any questions for me?
Well, I just would say exactly, the same thing is when you're a learner, you think it's sexy to get into, all the Doppler and the measurements and stuff. But, for me, I think you really do the best. If you're not in the ICU environment where, you can really spend one-on-one with a patient, spend 30, 40 minutes doing all the fancy stuff, I think you're doing more good for your patients in the ED environment where you scan 6, 7, 8 patients do it all qualitatively, all eyeball measurements, answer those, 5 or 6 key questions, add 2 or 3 minutes of lungs in, look at the aorta. You can realistically do that in 5 minutes. Use the clue exam or use the radius exam or something of that sort of protocol. I think works quite well. And I think you do a lot more benefit than spending the same amount of time on 1 or 2 patients doing, twice as many views, all the apical views, this suprasternal, add in all these views, add in all these measurements, because do you really want to miss that pericardial effusion because that was the one that you didn't scan? Or the person with the occult severe cardiomyopathy with a 20% ejection fraction who happens to be 25 years of age and has poisoned his heart from drugs, but, he looked fine, so you would have sent him home. I don't think you want to miss those things, and I 100% agree, don't underrate a 4 or 5 minute 2D cardiac exam with some lung, and use it as a screening exam.
Absolutely. I know we often have people who want to get into it and do a lot of fancy measurements, and some of them aren't necessarily fancy. Some of them are quite simple, but the reality is, unless you can get really good quality B-mode pictures, those measurement parameters are not accurate, and you can overestimate, underestimate things. If you haven't got a good B-mode picture, you can't get good color filling and good Doppler measurements. So without being able to get good B-mode images, then the rest is neither here nor there. So especially early in the journey learning cardiac ultrasound for point of care, it's concentrate on getting good quality images. And, that's a lot easier to do if people have a glass chest. The reality is when your patients are sick, it's very challenging, and you're not going to be able to get 4 beautiful views all the time. So the reason there's 4 is so that you've got some backups. And if you don't get a good parasternal long view, perhaps that patient is the person that you get a really lovely apical 4-chamber view. But it's really, really important to be practicing getting good quality B-mode pictures. And there's a whole heap that you can tell from that without going down the path of measurements and Doppler. Now, that does come, but look, I've seen it written some places too, like level 1 echo, level 2, level 3 echo. And I kind of think that level 1 is good B-mode pictures. Level 2 is we start to do a couple of measurements. Maybe we're doing TAPSE, maybe doing fractional shortening, maybe an ejection fraction. And then level 3 is the full-blown echo exam that should be left in the hands of people who've done 1,000+ echo exams. So I'm thinking, look, some of the different societies have a requirement at 30 scans for basic competency. And if you had 30 nice normal people in a row, you could probably scan a normal person. I think the reality is it's more like 60 to 100 before you start to be feeling confident and show competence at that basic 2D echo exam. And then we need to move up to 300 exams before you are competently performing those basic echo measurements. And then we move up to 1,200+ exams before you're being able to do that in-depth echo, which the echo sonographers or the DDU qualified docs do in point of care. You need 40 minutes sometimes to do those. And if your patient is sick, it might take longer. So, on your patients that are sick, this all gets a whole lot more difficult. So, those are sort of, they're not scientific benchmarks, but they're the sort of numbers I have in my head from when I'm watching people and how their skills develop. And certainly the first level is a good B-mode exam.
And
very interesting for you to quote those numbers, because within our Piper team, which are the group that go out and retrieve sick babies from Victoria and New South Wales, they believe they can teach them to detect TGA very quickly, and I'm very anxious that they're going to be the the points they've set for competence are way too low. So I do find I think a straight linear 2D measurement, probably, a femur in an obstetric scan probably requires 20 to 30 exams before you will be competent. But echocardiography is another level again, and I'm very interested to hear you say 60 to 100. It makes me feel far less like I'm standing out on a rock by myself.
Yeah, look, I think they're not numbers that are quoted in papers. They're not scientifically evaluated numbers by any stretch.
There are some.
We've supervised a lot of people doing whichever qualifications where the cutoff is 25 to 50, and I still see, like, those people can get through a normal scan on someone who is normal, and they can get the views on someone who has a glass chest.
Yeah.
Whether they can get a really nice view on someone who is sick, most of the time they really, really struggle. And so, like I said, they're not scientifically quoted numbers. I think all of the literature, or all of the qualifications certainly that I've seen in this country, are all very light on in their numbers when they're quoting competence. It's a basic benchmark, and it relies a whole lot on the fact that the clinical judgment is very strong. But based on just ultrasound skills alone, I think they're all a little bit light on, and this could be a very long and healthy debate and discussion. I mean, it could be highly controversial, but it depends too. If the only thing that people are scanning is echo exams, 30 scans is nowhere near enough. But if they've done 25 fasts and 25 aortas and 25 gallbladders, maybe then after all that 30 scans at echo is enough, because at least they can hold the probe and manipulate the probe. But if echo is the first thing, 30 is barely enough.
Yeah. My degree of difficulty, I guess of those images that you showed, I really struggle with the subcostal view. Unbelievably, I can't show all four chambers. Tips. What are your tips for a
so
subcostal
when you're scanning the subcostal view, are you holding the probe the same way you do for an abdomen scan? Or are you coming in
on top?
Pistol grip over the top.
Yep.
A lot of the time it's you need to get almost flat on the chest.
Mm-hmm.
Sometimes a breath in can help. It depends on how the heart's sitting, and in the textbooks it sits at this 45-degree angle, and in reality it's nice, but it doesn't. So come quite flat, breath in. Sometimes if you have them bend their knees, it just makes the tummy a little bit softer. But you've got to dig. You've got to really dig. So, and the guys that have, and I don't understand how they get such solid beer belly, the drum beer bellies, they're going to be hard. It doesn't matter what you do, because they're so solid, and it doesn't seem to matter how hard you push, there's just resistance. So if you bend the knees up, it can soften the tummy a little bit, but you do have to use quite firm pressure and get under the xiphisternum. I start in the midline, just under xiphisternum, and I start by pointing my probe directly up to the chin. So a common thing that I find with learners is they think the heart is a left-sided structure, and technically it is. But if you look at a chest x-ray, where does the heart sit? Right in the middle. And so I find that a lot of learners will think that they have to point the probe way out to the left, and they're missing the heart. Most of the time, if you point the probe to the chin or just to the left side of the chin, you've got enough tilt on it. Every now and then you can use the left lobe of liver as a window, so come a little bit to the right of midline, and then use the liver as a window, which means you do have to point it and angle it a little bit further. But a lot of the time, I think people aren't flat enough, and they're pointing far too far to the left, and the heart is sitting in the center of the chest.
Thank you. I will try all that tomorrow.
I think everything Suean said, I think compared to the other two views, I try to get them to not look at the screen straight away. I try to get them to concentrate on their positioning first and where they're pointing the beam, and I block them looking at the screen. And then I ask them to aim for left parasternal, because as Suean says, they either aim towards the nipple and the left shoulder and they're too far left, or they're straight up towards the sternal notch and a little bit to the right. I'm sure you do this, make sure you've got enough depth. Better to have too much, especially if you do that, as Suean said, that backup movement of going 3 or 4 centimeters to the right of the midline and shooting through the liver at the costal margin. You're going to need a bit of extra depth for there because you're a bit further away from the heart. And obviously, like a lot of things with ultrasound, combining things. So a deep breath in and fanning the beam anteriorly and posteriorly at the same time. Patients are variable, but actually I think subcostal view in most of my patient population works quite well, because a lot of them have occult COAD, even if they don't know it. So they're quite hyperinflated, which makes their subcostal view good, as you know, but their apicals more challenging in particular. Yeah, so that would be the only things I add.
I mean, I think I'd emphasize that point of, if you're struggling to see, and I get my learners to do this all the time, if you can't see the anatomy that you want to, I find that they just get so absorbed, and people are so concentrating on the image and they're really disconnected from their hand. So I always try to cover the screen and ask them to look and try to visualize the anatomy and point the ultrasound beam where you expect the anatomy to be.
Like a pistol or a laser beam. To hit the structure.
And it solves the problem so often.
Like the abdominal aorta, and how often is it they're not on the midline, and I say, where's the umbilicus? Like you're like 5 centimeters from the midline, and they don't.
I've actually seen someone scanning on the right side looking for the right kidney, and they've drifted and slid so far and they've seen an image of a kidney come up on the screen, but they're actually imaging the left kidney because they were so completely disconnected from what their hand is doing. So that's a really important tip for anyone as they're doing it. If you're lost, stop looking at the screen, look at your patient. Where do you think the anatomy is going to be? The doctors also, as you put on the ECG dots, I understand. I don't know how to do an ECG. But apparently you can tell the axis of the heart based on how that ECG looks. I think so. The docs have an idea in their head about how the heart is sitting. If you've got a really short barrel-chested guy with hyperinflated lungs or whatever, the heart will sit more horizontally. And so getting your windows is going to be in a completely different spot to the normal, healthy, fit young person with that heart sitting at the classic 45-degree axis. And so, figuring out where you think the anatomy is, looking at your hand position and pointing your probe in the general direction often can solve a lot of problems. And you might not be flat enough or too flat, and it's trusting that, hey, just go horizontal, maybe come back, depends on how the heart's lying.
I do like the idea of looking at your hand. I mean, I know I do that teaching general ultrasound. Where is the kidney? It's not going to be where you've got the transducer. I do that constantly, and I think I have to try that for the subcostal view. I mean, in pediatrics, we do have ideal patients, so I do expect perfect images every time, and maybe it's still just not possible to get perfect images every time.
Look, sometimes, and depends if they're coming in with all sorts of congenital problems. Those hearts can do weird and wonderful things.
Yes,
and so I think the parasternal, the parasternal long axis is great because it guides you to at least the line that the apical window is going to be on. So I would strongly encourage people to always, if they're planning on doing an apical window, they try to do the parasternal before they attempt the apical.
Yep.
Absolutely. And I always get them to look over the top of their hand, looking over the top of your hand to see where's the long axis of the probe, and thinking about where that long axis of the heart is. That guides you for your short axis. It guides you for where you need to point on your subcostal. I then follow it down, come around to the apical, and then you transverse your probe to get to your apical view. I personally have found that the most helpful, because the apical view can be, and the other one that I have in my head, the lady that I learned from, I've got this American voice in my head, walk the walk. And she talks about walking the probe to find a window and, doing the window shopping, browse the racks or the rib racks. So, be really adventurous with your window shopping. Go and the parasternal long, go one more window lower, because sometimes it's sometimes and often you think you've got a good picture, and then if you go one rib space lower, it's even better. So be adventurous, looking for the window, walk the walk, or browse the racks, window shop, whatever you want to call it. Be adventurous looking for that window, not these tiny little micro movements. Once you've got the window, then we're just doing these feather light micro movements.
I always tell people with a parasternal window to keep going down until your view deteriorates. And then at least you know at which point you're going downhill, and then come back up. Because as you said, if you don't interrogate the next space, how do you know that it wasn't even better than the one you had? And I think, this saying, stick to the basics, 2D, ask some fundamental 5 or 6 questions works really well with the current handhelds, because the picture quality, I believe, is definitely good enough to give you that information. You don't need to have, a $50,000 to $80,000 laptop or cart machine. These brands, we know what they are, the devices. They will more than do the job on answering these questions. And I think that's great, because it opens up, for everyone, including, people out in their rooms and people in general practice in the country, and everyone doesn't have to break the bank to be able to do this.
Yes, I agree completely with that. So, and that was really helpful. I'm glad I'm clinical tomorrow, and we'll test out exactly what you've said.
Have a crack.
Now I think about it, I'm not going far enough to the right before I angle to the left, and I'm not fanning. I'm not flat enough against the abdomen. So I managed with the other 2 views without a problem, but I was teaching the subcostal view today, and I struggled, and this patient should have been really easy. So
having been teaching the sonographers today, the view that you get hepatic confluence?
Yes.
Flatter than that.
Yep.
Flatter than
so
that.
Just keep
it's
going.
Further than that.
Yep.
Yeah.
All right. This was wonderful.
Get right up under the zippy sternum, because sometimes I see people, they're like 3 centimeters, 4 centimeters away from the zippy sternum, and there's sort of a bunch of fatty tissue in the way. And I think, and when I sort of shove it up that extra 1 or 2 inches, it just makes a difference in some patients.
Yep, I understand that.
Cool.
Thank you. I will
No worries.
share the link far and wide. Thank you, Suean, for the effort.
Thank you, Suean. Great
no
talk.
worries. And if any of your crew have questions for next month, the topic's wide open. So email me with your topic suggestions, and hopefully next month I come to you and we're out of lockdown, which will be super exciting.
Yeah, we won't know ourselves.
We won't. No one will be online, hopefully. They'll all be outdoors. Thank you, Suean.
Bye. Thank you.
No worries. Thanks, guys.
Good night.
Good night.
Night.